Hi, everyone. My name is Aylin Tansel, and today it's my pleasure to discuss some early results from a project that I'm working on with Tom Abel. The talk is going to be broken down into a brief background, followed by the results of the two parts of the survey. Within each part, I will discuss both the current results and the future directions. So first, a bit of background. Patients with gastroparesis, they have pretty significant symptoms of nausea, vomiting, abdominal pain, early satiety, and bloating. Depending on the severity of these symptoms, they may need to go to urgent care, emergency room, or even be hospitalized for their symptoms. While there is a little data on emergency visits and hospitalization usage, it's still pretty limited and still pretty early, and this is a big group that really is underserved in terms of how many patients are being hospitalized. Part of that is because while the ICD 9 and 10 code for gastroparesis exists, sometimes patients are have other codes like nausea, vomiting, inability to tolerate PO, and so it's hard to track that those patients specifically are gastroparesis patients or not. And so a large percentage of patients are probably underrepresented when we use large healthcare data. Additionally, there's no data available on how frequently patients are going to the urgent care. So the aim of this survey was to look at how often these resources are being used within a 6-month time period, and are there certain predictors for patients that are high risk to go to urgent care, emergency, or be hospitalized. The second part of the survey was to look at medications that are being used to alleviate and manage these symptoms. While knowledge of adverse effects exists, real-world data is limited, and a lot of patients, they don't just take one medicine, they take 5. And so how frequently are they cycling through these different medicines with adverse effects? We don't know. So the second part was really to explore what medications patients are actually taking, and what adverse effects are they experiencing from these medications. Perhaps there's a medicine that we're using in a high frequency that results in a lot of adverse effects, and maybe we need to rethink where we put that. So we dispensed the survey at a tertiary referral center, and patients were instructed to mail back the survey with a pre-stamped envelope. And we collected information on demographics, socioeconomic data, clinical variables, information on urgent care, emergency visits, and hospitalizations, as well as medication usage and adverse effects. And because there's this response bias where if you list an adverse effect, patients might have a recall bias, we kept the questions pretty open-ended just to see what patients thought that they were experiencing, and we didn't want to lead them to say something. So just what their experience is. So far, we have received surveys from 62 patients, and it's my pleasure to share the early findings. So most patients are women. The age range was relatively well divided among the 3 groups, with the youngest group making the largest distribution, the 18 to 44-year-olds. Most patients were Caucasian, and a really alarming, almost half of patients are unable to work. And I mean, I see this frequently in my clinic. The symptoms just make it very difficult to go to work. In terms of schooling, most patients had done at least some college. Most patients had Medicare. Many patients were low income. Some of this low income is because they need to be low income to get healthcare insurance. Most patients lived with other people. A disturbing third of patients have depression and anxiety. And since we are looking at adverse effects of medications, a lot of times that's going to be influenced by what type of active known drug allergies patients had. So we collected a little bit of data on that. Penicillin and sulfa allergies were the most common. And 8% had allergy to adhesive or tape. And so maybe we need to rethink better adhesive strategies for our patients. We also looked at marijuana usage, mostly as a predictor for the emergency usage hospitalization group. And 14.5% patients reported usage. Most patients were just taking it a few times a week, but 2/3 reported some benefit for their symptoms. And this is kind of the general makeup of the symptoms that patients have. So most patients have stomach fullness, nausea, bloating, and a large proportion of patients had issues completing a meal and issues with constipation. So now we get into the results of the first part of the survey, which is looking at urgent care, emergency visits, and hospitalizations. So 18 of the 62 patients, or 29%, had done at least one urgent care visit within the prior 6 months. 2/3 of these patients, it was gastroparesis related, regardless of whether it was a gastroparesis related reason or non-gastroparesis related reason. Most patients were going 2 to 3 visits within that 6-month period. And then for urgent care, more than half of patients reported an emergency visit within the prior 6 months. Majority of those were gastroparesis related, and regardless, again, of whether it was gastroparesis related or not, on average, they had 2 to 3 ER visits within the 6-month time period. So this is clearly a large population. Most patients of the group that we surveyed had an emergency visit. So we need to work on that, knowing how pleasant emergency visits are. And then hospitalization. So slightly more than 1/3 of patients were hospitalized. 3/4 of them were gastroparesis related. If it was gastroparesis related, it tended to be a very short stay, so less than 1 day. And then if it was non-gastroparesis related, it tended to be a 2 to 3 day stay for most patients. And of the 16 patients that had a gastroparesis related hospitalization, the most important symptom was nausea and vomiting. And that makes sense in the sense that inability to tolerate PO is a reason for admission. And then while still early, we did examine univariable and multivariable predictors. And because this data set is small, it was the confidence intervals were large for most of the risks, but we found that age of 45 to 64 seemed to possibly be a predictor for urgent care usage. For emergency department, we didn't really find a significant risk. And then for hospitalization, low income did appear to be a significant risk factor. And so as we get more patients, the confidence interval will get more narrow and we may be able to see more predictors. So the take-home points. So 1 in 5 patients had an urgent care visit. Half of patients had an emergency visit, and 1/4 of patients had a hospitalization. And the high proportion of patients requiring acute care is a significant concern. It should be a reported outcome, and it would probably be beneficial when we're looking at outcomes for gastroparesis patients if we use this as a health outcome prior to the intervention. Prior to the intervention, what is the 6-month rate? And post-intervention, what is the 6-month rate? And then future areas of research is mostly to pin down what are the reasons, who are the people, and how do we get them to not need to go to the emergency room? Are there ways that we can rehydrate patients? Urgent care may be a better place for some of these patients than going to the emergency room. And it may be possible that some of the newer medications for nausea, such as aprepitant, which are expensive, those may be cheaper than an emergency room visit. And so that might be a way to bring it up with insurance companies that these medicines should be covered. So really the main purpose of the survey is to measure the problem, and then because we'll have the measurement, we'll be able to measure the effect of interventions in the future. And so the future direction for this survey, we wanted to shift it to an online survey so we can recruit more patients to fill it out and better determine rates and predictors. Additionally, with COVID, I guess one of the very few upsides is this access to virtual healthcare. And more insurance companies have covered it, and we've been able to offer it to patients. And so this may also have the potential to reduce urgent care and emergency visits if you can see your doctor faster and easier. So, so this is something that wasn't the original intent of the survey, but it's something that may be good to explore. So the second part of the survey was looking at what medications are patients being exposed to and what is the prevalence of adverse effects. So we have to do this as a survey because clinical trials, they cherry pick their patients to maximize the measurable effect. Meta-analysis and melding data from clinical trials with different patient populations, different measured outcomes, different study design. And as I mentioned earlier, patients aren't just taking the one medicine, they're taking 6. So but I don't even know, are they really taking 6 or are they taking 8? So we really need real world data. And so the main real world questions of the survey: how many patients are being exposed to a drug? How many are having an adverse effect from that drug? And while difficult to quantify, it's something to think about, is how serious are these adverse effects that patients are experiencing and reporting. So let's start with the first medicine that I know Dr. McCallum had mentioned, metoclopramide. And so almost 3/4 of patients had reported past or current usage, and more than half had adverse effects. The most common adverse effects were tardive dyskinesia or another neurologic symptom. And I think that speaks to how long these patients are on Reglan before they go to a motility center, because the baseline prevalence of patients with tardive dyskinesia is quite high. And then looking at other prokinetics, so more than half had taken domperidone, a little more than 1/3 had adverse effect, so appeared to be better tolerated. The most commonly reported adverse effect was lactation. Erythromycin, almost half, less than half, had taken erythromycin at some point. About 1/3 had adverse effects, and most commonly that was a GI complaint of nausea, vomiting, cramping, etc. And then what about antiemetics? So Zofran was the most common. So 4 in 5 patients had tried Zofran, and 1 in 5 had maybe an adverse effect, and headache was the most common adverse effect reported. Phenergan was the next most commonly used, and so 3/4 of patients had reported past or current usage, and about 1/3 had adverse effects, and the most common effect was drowsiness. And then scopolamine, less than 1/3 had tried that, and blurry vision was the most common side effect. And aprepitant, which is one of our newest ones, very few people reported ever being exposed to it, likely due to the cost of the medicine, but at least in the very brief brief number of patients sampled, they hadn't experienced any adverse effects. And then a whole list of other medications used. So Benadryl, more than half, most commonly drowsiness, Ativan, and then some of the medicines were less commonly used, so like Zyprexa and Buspirone. So it's kind of difficult to say, to really use those numbers of adverse effects. And then Haldol. So Haldol was the original reason that Dr. Abel and I were really kind of starting this survey, was because a lot of patients a lot of recent data has been looking at Haldol for refractory nausea, specifically in the emergency room. So that was actually the original aspect of where this study kind of started. And so so interesting, 11 patients reported exposure to Haldol at some point, most commonly in the emergency room. And we left a lot of open space and for really to get patient input, as this is really an early phase of the survey. And patients reported that they weren't advised of adverse effects, and that they were not given the option to refuse the medication. And 3 out of the 11 reported an adverse effect. And the effects that they reported were made my body feel weird, skin crawling, disorientation, nausea, allergic reaction. And only 3 of the 11 patients reported benefit from Haldol. So really 3 patients are experiencing an adverse effect, 3 are maybe experiencing a benefit. Well, that leaves 5 that it really neither helped nor hurt. And so that was maybe an unnecessary exposure to a drug. So future directions, certainly to expand the list of medications you assessed, and to also ask the benefit of the medications. That's kind of what I realized when I was looking at the adverse effects is that, well, when I want to put it in the context of an algorithm, I want patients to get the most beneficial drug with the least harm. And so the future direction of the survey is to look at how much benefit are patients getting and how harmful are patients getting, and then we can kind of sort that into a risk-benefit ratio. Obviously, everything is about cost, so that will further be a further aspect is looking at cost. And can also explore if certain patient phenotypes might experience more adverse effects and less benefit than other populations. And so that's kind of a nice thing about the surveys. We can look at race and gender and identify because there may be certain groups that are underrepresented in a lot of these trials that are experiencing adverse effects and less benefit. And then certainly there's a realm for integrative medicine or complementary medicine. For instance, ginger is commonly used for nausea, may have some benefit and very little harm. So it may be possible that that may be better used as a first-line agent than Zofran. And the main things I think about when medications is, can it work? So efficacy, does it work? Effectiveness, is it worth it? Value, and is it used? Utilization. And I wanted to thank everyone that has helped to do the survey, all the patients that have filled it out. Thank you to the Oley Foundation for letting me present the findings. Thank you to you, the listeners. I hope that I can get your help with the survey, and certainly please stay safe. Thank you very much.